So this is a new concept, a CME with a difference. Thanks to our all the faculties who have allowed us. And I tell you, 75 days we have completed the launch all across India. Mumbai CME hui, Trivandrum CME hui, Chennai I was there, but somehow something was missing because UP में नहीं हुआ. और राम जन्मभूमि में ना हुआ तो वो काम अधूरा रहता है. अभी कुछ डॉक्टर बोल रहे थे कथा शुरू किया जाए. So this way now the cycle has completed after the launch of 75 days. So thanks to all, and before we deep delve, let me take the opportunity to welcome Dr. Sudeep Sircar himself, who is a renowned name in the field of diabetes. लखनऊ और लखनऊ के हेल्थ केयर को इन्होंने बढ़ते देखा है पिछले 25 सालों से. So let's have a huge round of applause to sir, and then we will proceed further.
Thank you. First of all, thank you UPDA and especially Dr. Manoj Srivastava sir for giving me this opportunity, and Zuventus people for giving us this platform. So first of all, we start the proceedings, and I welcome the chairpersons on the dais. There are few prominent physicians of Lucknow. First of all, in order of seniority, I will invite Dr. Ajay Kumar Chandra sir on the dais. He is a very well-renowned physician, cardiologist. Dr. Sanjay Arora sir, please welcome to the dais. Again, he is a very known figure in the Lucknow fraternity, physicians fraternity. Welcome Dr. Sanjay Arora sir, thank you for joining. And last but not the least, one of my very good friend, Dr. Satish Joshi sir. Now it's up to you sir, chairpersons, for the introduction of the speaker.
Hello everybody, it's a pleasure to introduce Dr. K.B. Chandra, one of the most renowned diabetologists in the city. He is a fellow Indian College of Physicians, a fellow of Euro-Asian Academy of Clinical Diabetology, fellow Indian Society of Hypertension, fellow UPDA, fellow Indian Society of Chronomedicine, fellow Research Diabetes India, fellow International Society of Medical Nutrition, and fellow Indian Academy of Clinical Medicines. He's got over 30 publications, original research, book chapters, patents, and review articles. Everybody knows him to be a very jovial person. Let's hear what he has to say about Trelagliptin.
Thank you, sir, for your kind words. Good evening, ladies and gentlemen. At the outset, I would like to thank UPDA, Manoj Srivastava sir, for giving me this opportunity to talk about Trelagliptin. Trelagliptin is Trelagliptin, once in a week DPP4 inhibitors. So I'm just going to talk about it. So a little bit introduction was given by Zuventus people that one of the biggest challenge that we do have in chronic disease therapy is the compliance, and a number of tablets affects the overall result. And if you are able to achieve the same goal with less number of tablets, probably you will be giving better results. And what I believe in is Trelagliptin is one of the attempt to solve that problem. Whenever we talk about diabetes, we keep talking about the progressive nature of the disease, and then when you start therapy, we all think about the cost, lifelong therapies, and then we try to find out if we are able to address the pathophysiology associated with disease. So over the time, our understanding about treating diabetes has changed a lot. Well, I mean, the first drug after insulin was sulfonylureas. That evolved over the time, and then we were too much focused just on treating blood sugar level. However, over the time we thought that treating blood sugar is not enough. We need to treat diabetes in such a way that we are able to decrease the complications associated with diabetes. And then we moved towards pathophysiological aspect and tried to understand why diabetes occurs. And if we do have some way or the other by which we can target the pathophysiology of diabetes, and that's why the pathophysiology of diabetes, which include increased beta cell apoptosis, increased hepatic glucose production, and decreased muscle uptake, DPP4 inhibitors came in. The Defronjo had given the ominous octet telling us about the pathophysiology of diabetes, and over past couple of decades, I would say, incretin based therapies and DPP4 inhibitors have done a wonderful job in trying to address some of the unmet need that we did have in management of diabetes. These are known facts that despite all these treatments, about 2/3 of the diabetic patients are still not adequately controlled, and poor medical adherence is one of the cause of them. और अभी हम लोग थोड़ी देर पहले बात कर रहे थे बैठ के कि आप दवाइयाँ कुछ भी लिख दीजिए, लोग आते हैं बोलते हैं, मतलब although this is not the right place to say, but जन औषधि से जाके दवा लेते हैं और कहते हैं कि दवा काम नहीं कर रही है. Meaning thereby cost sensitivity, number of tablets. Most of the time, I would say around 70% of the patients coming to our clinics spend out of their own pocket. They do not have, reimbursement, and that's why adherence and cost become one of the important factor. Needless to emphasize that poor adherence will certainly have worse HbA1c level. Whenever we talk about increasing the adherence, we often talk about fixed dose combinations so that number of tablets are decreased. And there are studies which has shown that a 10% decrease in adherence leads to around 0.14% increase in HbA1c level. And that's why once weekly regimen are linked with improved and better long-term outcome. So friends, this evening, when I will be talking about this new molecule, I will be trying to give some data that they have from around 3,000 patients' clinical research data, where they have tried to prove that once weekly DPP4 inhibitor is as efficacious as once or twice daily DPP4 inhibitors which are available. So before I go to the particular DPP4 inhibitor we are going to talk about, let us summarize or let us recap what are the once weekly therapies that are available at this point of time with us. So couple of DPP4 inhibitors, Trelagliptin I am going to talk about today, Omadagliptin, then we have GLP-1 receptor agonist which includes exenatide once weekly. Dulaglutide was being marketed in India, but recently I believe Eli Lilly is not too much aggressive for that once they have withdrawn. Once weekly semaglutide has already been launched in India, so we have got different strengths of Wegovy now, and tirzepatide was launched couple of weeks. So these are injectable therapies. And then once weekly insulin, Icodec and Ifcitor Alpha, these two are in pipeline. We were informed that Icodec was to be launched this year only, but there are some regulatory delays and probably Icodec is going to be launched next year somewhere. So these are once weekly therapies, and let me tell you, you all might have experienced in your practice, बहुत सारे पेशेंट आते होंगे बोलते हैं डॉक्टर साहब वो हफ्ते में एक बार वाला इंसुलिन आ जाएगा तो बताइएगा, डेली इंसुलिन नहीं लगा पाएंगे. So yes, people prefer that if the frequency of dosing, I mean हफ्ते में एक बार ले लें और पूरे एक हफ्ते you are free, so that will become easy for the treatment. So Trelagliptin is once weekly oral long acting highly selective DPP4 inhibitor. Talking about chemical formula, I don't believe is of much importance to this audience. However, whatever fluorination was done, the aim was to create a compound with improved pharmacokinetic properties, allowing for less frequent dosing. So they have put fluorine in place of hydrogen in the benzene ring at 5th position, and that had led to improved chemical stability against metabolic degradation, increased binding affinity to DPP4 enzymes, so its potential to inhibit DPP4 is increased. There is increased elimination half time, 54.3 hours, making it suitable for once in a week dosing. Slower dissociation from DPP4 enzyme and increased selectivity and specificity for DPP4 enzyme, so that off-target effects are minimal. So fluorine atom has added these benefits. Now it's a potent inhibitor of DPP4 and it exhibits 2.7 and 12-fold more potent inhibition when compared to vildagliptin and sitagliptin. So we all have vildagliptin and sitagliptin, and we have got enough experience of using these two DPP4 inhibitors, and just comparing Trelagliptin with these two DPP4 inhibitors give us a lot of confidence about the potency of DPP4 inhibition being done by Trelagliptin. It has got slower dissociation. You can compare it once again with vildagliptin and sitagliptin. You can see around 15 times slower dissociation. So prolonged DPP inhibition is done. it has got increased selectivity and specificity for DPP4 enzyme. So there was always, I would say a decade back when we used to have CMEs for DPP4 inhibitor, selectivity for DPP4 enzyme was talked a lot. And the purpose was that DPP4 enzyme is associated with glucose mediated insulin release in pancreas. However, there are other DPP enzymes which are essential. They include DPP2, DPP8, DPP9, and they are essential for different metabolic activities in our body. And if I have to have a safe DPP4 inhibitor, its selectivity to DPP4 enzyme has to be much more in comparison to other isomers or other DPP enzymes. And here we do have a DPP4 inhibitor which has got selectivity more than 1 lakh times in comparison to DPP2, DPP8, DPP9. So off-target activities is expected to be very less, and this drug is expected to be safe, anti-diabetic, and the concerns that could be because of inhibition of DPP enzymes other than DPP4 is less with Trelagliptin. Increased elimination half-life, needless to repeat. The pharmacokinetic profile which has changed gives it a very long half-life and makes it suitable for once weekly administration. As we talk about mechanism of action, we all know DPP4 inhibitors work through incretin hormones. Incretin hormone potentiates glucose stimulated insulin secretion from beta cell in pancreas. GLP-1 causes a reduction in glucagon release and decrease in gastric emptying, and incretin cleave rapidly to inactive form by DPP4 enzyme, and DPP4 inhibitors retard the degradation of incretins, and that's how it helps in adequate or appropriate insulin release, which is mediated through glucose. Let us talk about bioavailability. Since this is the launch of Trelagliptin in Lucknow, we need to talk a little bit about the basic pharmacokinetics of this drug. I understand for clinicians it may be a little bit boring, but at least we should know the drug which we are talking about at least once. So bioavailability 85%. हम लोगों के लिए बहुत ज़्यादा यूज का चीज़ होता है क्लिनिकल डेटा कि ड्रग सेफ है, HbA1c कितना रिडक्शन हो रहा है, ड्यूरेबिलिटी क्या है, OAD फेल्योर क्या है. So I will be talking about those data also, but yes, a little bit basic things about pharmacokinetics. Bioavailability is 85%, half-life 54.3%, and excretion is mostly through kidney. So that is important that we need to understand. Since its excretion is through kidney, whenever there would be compromise in renal function, we will have to decrease the dose of Trelagliptin. So this is important aspect that we need to know about pharmacokinetics. So this drug has been approved for treatment 100 milligram orally once a week for treatment of type 2 diabetes, and dose adjustment have to be done the way we did for sitagliptin. 100 milligram when kidney functions are normal, eGFR more than 50. 30 to 50 you decrease it to 50 milligram once in a week, and when it is less than 30 it has to be 25 milligram once in a week. Since it doesn't go any metabolism in liver, no dose adjustment has to be done in impaired hepatic function. As far as pregnant women and lactating women is concerned, there is no specific study done for its safety in human in lactating and pregnant women, but animal studies suggest that it passes placenta, it is secreted in milk. So I would say we should avoid using it during pregnancy and lactation unless we believe benefit is more than expected harm. Contraindications: do not administer to following patients: severe ketosis, diabetic coma. We all know severe infection. In all these situations, the treatment is insulin. So don't try to play around with DPP4 inhibitors, SGLT2 inhibitors, metformin or other. In all these critical conditions, you have to treat the patient with insulin. So these are standard contraindications, and I wouldn't be taking too much time. Safety: no serious adverse effect. Overall, we have seen that DPP4 inhibitors group of drug are as such very safe. As far as efficacy is concerned, they may not be highly effective, they are moderately effective. HbA1c reduction with DPP4 inhibitors are in the range of 0.5 to 1%, but the beauty is that they are safe, and particularly in the scenario that we do have, 50% of our patients forget follow-up visits. I mean, they would take the prescription and may come after 2 months, may come after 6 months, may come after a year, and डॉक्टर साहब आपने जो दवा आप ही की दवा चल रही है. तो ऐसे में वैसी दवा जिसमें कि साइड इफेक्ट कम हो, रिस्क ऑफ हाइपोग्लाइसीमिया कम हो, हफ्ते में एक बार लेना हो. I mean, these good features, or I would say these safety features of the drug would certainly help us in treating our patient with Trelagliptin. Clinical trial data to date suggests a similar safety profile to once daily DPP4 inhibitors with both once weekly DPP4 inhibitors that are available. Certain instructions to the patient: standard instructions should be taken once in a week, should be taken the same day of the week. If you forget to take on Monday, you remember it on Tuesday, take it on Tuesday. If you forget, take it on Wednesday, and from next time take it on Monday. So this is what standard instruction has to be given. What is the place of therapy of DPP4 inhibitors? I mean, this is the place of therapy for not only to Trelagliptin but any DPP4 inhibitor. Today we have individualized way of treating patients with diabetes, and depending upon the requirement, if patient has got ASCVD risk, you have to choose a drug which has got beneficial impact on ASCVD, and then GLP-1 receptor agonist and SGLT2 inhibitors come into the role. Patient has got heart failure, CKD, SGLT2 inhibitors come early. You need to reduce the weight. In that case, you need to choose a drug which has been found to have beneficial effect. Once again, GLP-1 receptor agonist, SGLT2 inhibitors, GLP-GIP agonist come. So the place of DPP4 inhibitor will depend upon the patient's criteria. So if there is no compulsory indication for using those drugs, and patient is not able to tolerate metformin, or metformin is contraindicated, this will become first line drug. Otherwise, it will become second line drug after metformin. If patient has got background of ASCVD, it will become third line drug. When adequate glycemic control is not achieved by first two drug. So if patient has got CKD, you have already given SGLT2 inhibitors or whatever other drug available, and you don't want weight gain to happen, weight neutral drug DPP4 inhibitors come in. So we have been using DPP4 inhibitor for more than 1 decade, and we all know what is place of DPP4 inhibitor in management of diabetes. Now this is important aspect. The way our society is changing, elderly people have less access to other family members who would care for them, and at times we do have children visiting their parents either at their home or in nursing home once in a week. And if we do have once in a week therapy, that would certainly improve the compliance, improve the result, and improve the quality of life. So for elderly diabetic with dementia requiring nursing care, reducing dosing frequency, once in a week solution would certainly be better. Utilizing a weekly drug formulation to decrease the number of daily medication may further alleviate caregivers' responsibility, making such formulation a valuable option for these patients. Few words about clinical data. Since we have to use this drug, we should have confidence about this drug has been given to people and we do have favorable results. So published clinical trials are there with around 3,000 patients in clinical trial. Oral bioequivalence study of Trelagliptin with the innovator Jaffa-Tech, that is with Takeda, has shown that this is bioequivalent to innovator. Dose finding study, which dose is efficacious? We all know that in phase 2 of the clinical trial, a drug undergoes dose finding study. So right from the minimum efficacious dose to maximum efficacious dose, dose finding studies are done. And you can see from 12.5 to 200 milligram dose was studied in phase 2 trial, and 100 milligram dose once in a week did show adequate response. Dose related increase in response was seen from 12.5 milligram to 100 milligram, but after 100 milligram the dose response had plateaued, and that's why 100 milligram was chosen as the most efficacious drug. Now comes Indian experience. This drug has been given in 240 drug-naive type 2 diabetic patients. Results have shown that HbA1c reduction was comparable to vildagliptin twice daily in the range of 0.9 to 1%. Long-term safety and efficacy of once weekly Trelagliptin as monotherapy or combination with oral anti-diabetic drug in type 2 diabetes has been done. So you can see 248 patients on Trelagliptin monotherapy, 158 patients as combination with sulfonylurea, 67 patients as combination with glenide, 65 patients with alpha glucosidase inhibitor, 70 patients with biguanides, and 72 patients with thiazolidinediones. So in all these, once weekly oral Trelagliptin provided a well-tolerated long-term safety and efficacy both as monotherapy and combination therapy in type 2 diabetes. Coming about severe renal impairment, I have already told dose has to be reduced. So Trelagliptin 25 mg once weekly is efficacious and well-tolerated, suitable for type 2 diabetes patient with severe renal impairment or end-stage renal disease. some real world studies, some real world data. More than 7,000 patients analyzed using Japanese medical data. It was a retrospective cohort study, used Japanese medical claim and checkup data, comparison of once weekly Trelagliptin, once a daily Sitagliptin, twice daily Vildagliptin, different groups of drug you can see. More than 79% of the patient who were on Trelagliptin achieved HbA1c target of less than 7%. So this is what we have got retrospective data with Trelagliptin. Efficacy and safety of Trelagliptin in combination with insulin. Once again, 52-week study, randomized double-blind study for 12 weeks followed by 40-week open-label trial. Trelagliptin combined with insulin significantly reduced HbA1c without increasing the risk of hypoglycemia, making it a promising add-on therapy for type 2 diabetes with inadequate glycemic control. As far as glycemic variability is concerned, over the time our understanding has evolved. We do continuous glucose monitoring, and variations in glucose level is what we try to avoid, because a lot of variation in glucose level is associated with increased CV complications. So when we do continuous glucose monitoring, we try to see the standard deviation of the glycemic variability, and lesser is the standard deviation, better is the control, better is the drug profile. And that is what we have been able to see, that overall DPP4 inhibitors improves glycemic variability, and Trelagliptin effectively reduces the glycemic variability and improves glycemic control without causing hypoglycemia. Now, one meta-analysis about efficacy and safety of once weekly Trelagliptin, 6 randomized trial, 981 patients, different parameters. Let us see the conclusion. Once weekly Trelagliptin shows good glycemic efficacy and is well tolerated in type 2 diabetes. So all these data or all these trials, I'm just trying to tell you all that this drug is not a new drug. We have a lot of comfort of using DPP4 inhibitor. This drug, basically coming from Japan, has been used there, and now it has been launched in India. And the added benefit that we do have in comparison to other DPP4 inhibitors is that it can be given once weekly. Its efficacy profile, its safety profile are comparable to time-tested DPP4 inhibitors that we have been using. Now, effects of Trelagliptin on beta cell function in patients with type 2 diabetes, randomized control trial, DUET beta study. This once again reminds me about the HOMA-IR, HOMA-beta function that we used to discuss when other DPP4 inhibitors were being talked a decade back. And results are similar with this also. Beta cell function was assessed using glucagon stimulation test based on deposition index. HOMA 2% beta significantly improved with Trelagliptin. Trelagliptin improves beta cell function. This is what we got. Then comes quality of life and treatment satisfaction. We have a lot of comfort with DPP4 inhibitors, and once weekly DPP4 inhibitor will certainly improves the quality of life and satisfaction. Similar glycemic control and safety compared to daily DPP4 inhibitor with improved comfort. We can easily switch from once daily DPP4 inhibitor to weekly DPP4 inhibitor. So this could be a question that may come, that patient is already on another DPP4, how to switch. So once weekly DPP4 inhibitors are effective, well tolerated, enhance patient satisfaction, especially in DPP4 patient by reducing dosing frequency and supporting better adherence, potentially leading to better long-term outcome in diabetes management. Cardiovascular safety. Although CVOT trials have been mandated and CVOT trial is not available with Trelagliptin, but traditional cardiac safety data which we have seen with other drugs before this CVOT trial became mandatory are already available with Trelagliptin. So Trelagliptin reduces glycemic variability. 52-week study confirmation shows that there is no QTC prolongation. QTC safety studies have been seen up to 200 milligram once week dose, and no negative impact on QTC was seen. Regulatory endorsement from Japan is already there. No cardiovascular risk or safety signals were seen in 52-week trial. No proarrhythmic risk was seen. So the advantages, time and again, same thing is being repeated. Once weekly, effective glycemic control, high potency, long half-life, beta cell function improvement, proven safety, cardiovascular benefit, renal and hepatic safety. So these are few things that probably this company is going to give us, some chatbot and all. So we do have Trelagliptin, which is as efficacious as other DPP4 inhibitor, as safe as other DPP4 inhibitor, with once weekly formulation, which is expected to improve the adherence, improve the glycemic control, and improve the quality of life. Thank you very much for your patient attention.
Thank you, Dr. Chandra, for such a crystal clear explanation of a new molecule. Please, Dr. Chandra, join us on the stage for the panel discussion. And I would also like to request Dr. Manoj Srivastava sir to join the chair for the panel discussion. Sir, is there any contraindication?
कंट्राइंडिकेशन बताया था सर, वही जो सीरियस है, आईसीयू में है, कीटोएसिडोसिस है, उन सब में नहीं देना है। रीनल फेल्योर अगर हो गया तो उसमें आपको 25 मिलीग्राम देना है। दी जाती है कंट्राइंडिकेशन। कॉस्ट बता दो भैया।
151 per tab.
150 रुपया
Per tab.
कॉस्ट इज सर 151 रुपीज फॉर अ वीक, मतलब 20 रुपीज पर डे का है, जो अपना कॉम्पेरेटिव है अरेबिलिटी, एंड इट इज फॉर 100 mg, दैट इज द स्टैंडर्ड डोज. वी हैव 50 mg and 25 mg as Dr. Chandra has mentioned, that is for CKD patients, मतलब less than 50 to 30 GFR, that is 50, and less than 30 eGFR is 25 mg. So till 8 GFR that study is there, this Trelagliptin can be prescribed. So that's the cost. 88 rupees for 50 mg and 65 rupees per week for 25 mg. So that's it. And this is something a unique thing, if you allow us, sir. So as sir has hinted, this is a chatbot. See, अपने पेशेंट को हैबिट है once in a day लेने का, twice in a day. ये chatbot will help patient in a reminder as a friend. वो जैसे ही स्कैन करेंगे व्हाट्सएप में एज अ फ्रेंड, उनको आ जाएगा हाय विनोद, हाउ आर यू, आप कब ये अलार्म सेट करना चाहते हो. तो जैसे डॉक्टर चंद्रा ने मंडे को प्रिस्क्राइब किया 9 बजे लेना, तो मंडे का वो डे सेलेक्ट करेगा 9 AM, हर एक मंडे को उसको सुबह एक अलार्म जाएगा. इफ़ ही मिस्ड तो 2 घंटे के बाद फिर दूसरा, इफ़ यू हैव टेकन द मेडिसिन, दैट वे दिस चैटबॉट विल हेल्प एज अ फ्रेंड फॉर द पेशेंट्स. Why it is put? Because it is for the first time in India. तो but obvious है कि पेशेंट्स आर बाउंड टू फॉरगेट, कितना ही आप लोग बताओ उसको. एंड दिस इज अ 4 टैबलेट, मतलब 1 मंथ की थेरेपी. एक वॉलेट पैक है जो हम लोग पर्स रखते हैं अपने पॉकेट में, तो 4 टैबलेट फॉर अ मंथ थेरेपी. सो दैट इज अबाउट दिस. या थैंक यू.
Somebody explain me something. Something came to my mind. We are using this in combinations, you know. People are saying that we can use this in combination, say with metformin. Like example ले लीजिए metformin. आपको एडवांटेज क्या मिलता है? मेटफॉर्मिन या तो आप वंस वीकली दीजिए तो एडवांटेज है, अदरवाइज यू आर गिविंग मेटफॉर्मिन एवरी डे एंड यू आर गिविंग 8th day, every 7th or 8th day you are coming up with a Trelagliptin. So what is the advantage? How do you give it? वो एडवांटेज हमें कैसे मिलता है? उसको गोली तो खानी है, आप ट्रेलाग्लिप्टिन और मेटफॉर्मिन एक कॉम्बिनेशन खाएगा, एक दिन एक कलर की खाएगा, एक दिन 2 कलर की खाएगा, और फिर 6 दिन जो है 1 कलर की गोली खाएगा. Look, until unless we don't, you people talk of once daily, once weekly. आप लोग once weekly एडवांटेज की बात करते हैं, तो once weekly एडवांटेज मीन्स कि the drug should be, हम पिल जो दे रहे हैं वो once weekly दें. हम पिल तो डेली दे रहे हैं, एक दिन हम 2 रंग की दे रहे हैं और बाकी 6 दिन हम 1 रंग की दे रहे हैं. Where is the patient's advantage?
Okay, so sir, this is a very valid question. Still, 2 गोली आप प्रतिदिन खिलाइए, प्रतिदिन 1 गोली खिलाइए और हफ्ते में 1 गोली खिलाइए, थोड़ा सा डिफरेंस हो जाता है. So what I would talk is the data that they had with once weekly. They did see that patient satisfaction, कुछ क्वेश्चन बनाए थे, उसमें patient satisfaction was seen to be more with once weekly tablet. So I agree to you कि मतलब को agree with you sir कि मतलब मामला तो है 2 गोली डेली खा लो, उसके बाद 1 गोली डेली खा लो, और आजकल तो कॉम्बिनेशन आ रहा है, तो कॉम्बिनेशन में वैसे भी 1 ही गोली सुबह शाम खाना है. बट मोस्ट ऑफ द टाइम once a day tablet, 2 tablets once a day versus once a day 1 tablet plus once weekly tablet. Once weekly tablet has got a better satisfaction. Number 1. Number 2, मुद्दा होता है बस एडहेरेंस का. हफ्ते में 1 दिन वो गोली खाना भूल गया तो कंप्लायंस 15% घट गया. हफ्ते में 1 ही दिन खाना है, कंप्लायंस इंप्रूव हो गया. तो ओवरऑल दैट लीड्स टू बेटर ग्लाइसेमिक कंट्रोल. सो दीज आर द 2 इंपॉर्टेंट थिंग्स दैट आई वांटेड टू से. कंप्लायंस इंप्रूव हो जाता है सर. 14 बार गोली खानी है, हम धोखे में 1 दिन भूल गए, 2 दिन भूल गए, 14 बार की जगह 12 बार खाए, हफ्ते में 1 ही बार खाना है.
एमडीसी दे रहे हैं, फिक्स डोज कॉम्बिनेशन दे रहे हैं, 1 टैबलेट दे रहे हैं,
बस वही मैं बोल.
अगर आप इसको वंस डेली दे रहे हैं, एक फिक्स डोज कॉम्बिनेशन दे रहे हैं, 1 टैबलेट डेली दे रहे हैं, तब तो कोई उसको एडवांटेज नहीं मिलता है. आप कह रहे हैं कि नहीं उसको 1 दिन 2 आप वंस डेली, अगर वो 1 दिन मिस करता है तो 15% एफिकेसी कम हो जाती है, हफ्ते में 1 बार मिस करता है. If your patient is taking 1 tablet every day and you ask him, I'm talking of Indian patients with an IQ level which is not comparable to the Western patients. Please.
They should not be compared.
Please. No comments. Yes. No comments. But education level आपको मिलेगा. आप जो है एक सब्जी वाला आएगा, उसको बोलेंगे कि बेटा आप ऐसा करो कि आप 6 दिन जो 1 गोली खाओ, 7वें दिन जो आप 2 गोली खाओ, वो 7वें दिन भूल जाएगा 90%.
सर विटामिन डी खाते हैं वैसे खाता है.
एडवांटेज
डॉक्टर साहब
थोड़ा सा और भी होता अगर उसकी कॉस्ट कंपेरेबल होती थोड़ी सी, मतलब इट इज ऑलमोस्ट इक्विवेलेंट इन कॉस्ट टू डेली प्रिपरेशन. बल्कि मेरे ख्याल से अगर ट्वाइस अ डेली आदमी खा रहा है या वंस अ डे कॉम्बिनेशन खा रहा है तो कॉस्ट ऑफ 7 tablets विल बी लेस देन दिस सिंगल टेबलेट. In addition, he has to take metformin also, most of the time with other drugs also.
So point taken, sir, and believe me, the CME is going in right direction as Dr. Chandra has mentioned, and this is the question bound to come. Means every CME there's such questions come. 2 things he has mentioned additionally. In newly diagnosed patients also can we prescribe this before metformin? It could be one alternative. जो young corporate patient है 20 साल का पेशेंट लेना इंडिया में एक स्टिंग माना जाता है कि अरे वो दवाई ले रहा है मतलब बीमार है. शादी ब्याह में लोग छुप के लेते हैं रूम में जाके अभी भी दवाई, तो वहाँ पे आपको 7 दिन पर टैबलेट लेना. आई एम टॉकिंग अबाउट न्यूली डायग्नोस्ड T2DM पेशेंट्स हैविंग 7 और 8 HbA1c. वहाँ पे आप डेली ना देखिए, आप इसको ऐड कर सकते हो. दैट इज 1 पेशेंट प्रोफाइल. Another, in place of metformin, you can start with this. Means this is what I have learned in different CMEs. Might be you know it better in different patient profile. You can use it. I've seen many prescriptions having SGLT2 plus metformin और डॉक्टर ने अलग से एक्स्ट्रा इम्पैक्ट के लिए once weekly ये ऐड किया ट्रेलाग्लिपिन. So I agree sir, once weekly अगर metformin ले रहा और ये once weekly तो drugs तो वही रहेगा, but additional patient profile में it can be given in place of metformin. Newly diagnosed patients could be the same. If Dr. Chandra would like to add something.
So this brings me to the one additional thing that I can think कि बहुत लोगों को metformin tolerate नहीं होता है, GI side effects है, वहाँ पे we may begin with once weekly Trelagliptin and that makes it a unique drug जहाँ की compliance भी अच्छा हो जाएगा. So this is one criteria of patient जहाँ पे कि we can believe this Trelagliptin is going to do wonders.
Patient who is on a single drug.
How many?
Patient who is controlled on a single drug, it is good for him.
How many times do we have patient on single drug? How many times do we have patient on single drug? Hardly any. What Dr. Chandra is saying is well taken that we have to go for combination and फिर advantage इतना नहीं मिलेगा. Other point which is conveyed by them is that it is a good add-on as once weekly. We are already trying to control the patient and we need something more. At that place, this molecule comes as a good one, that we don't have to increase one tablet daily for entire week. We just take one tablet per week.
So
That
I
is
think
one
we
big
have to
advantage.
Keep an open mind. Any drug is an add-on to, is an add-on to the therapeutics. So every drug has got its place, and you cannot just show it the gate कि आपको जिसको कहीं place नहीं है.
No, it's not a matter of showing the gate. एक चीज ये भी जान लीजिए कि कोई CVOT trials नहीं है इस drug के साथ, जो कि आजकल mandatory है basically. And as far as DPP4 inhibitors are concerned, I think except Sitagliptin, if I'm not wrong, किसी drug के साथ नहीं है.
नहीं लीना का भी है.
लीना और सीताग्लिप्टिन.
But
CVOT.
there's one thing we need to know कि echocardiography पे कोई effect है कि नहीं. Echo parameters whether it is having same your
No,
allogliptin के साथ
QTC
problem.
prolongation तो नहीं है, उन्होंने बताया.
Allogliptin के साथ problem है. That's why I was asking. बिल्ला के साथ. Allo के साथ भी है.
सेक्शन तो निकल ही गया, हट गया था वहाँ से.
Echo parameters के study चाहिए.
FDA approval भी नहीं है ना इसको.
There are some safety concerns about
DCT approval
this
चाहिए.
precipitating heart failure.
10 साल में 2015 में आ गई थी. 10 years now कोई significant long term ऐसी कोई स्टडी है इसमें सेफ्टी और टॉलरेबिलिटी?
ये real world study.
ये एक था वो रियल वर्ल्ड रेस जो दिया था इन्होंने.
Trials we have is 52 weeks. We need some longer experience with this. So most of the places 52 weeks के trials ही हैं. So once we are using this molecule, we have to keep in mind that side effect reporting करनी है. कुछ extra मिलता है, कुछ extra information मिलती है. We have to report that.
The other thing that comes to my mind is कि what to do in Ramzan and Navrans. Continue or discontinue?
It is quite a safe molecule. This molecule is quite safe, so we don't expect much problem with this molecule.
क्या करना है? क्योंकि
What you're saying is a good apprehension which was coming in my mind also, that my experience with one of the sulfonylureas in kidney failure, high dose sulfonylurea, the patient stayed in hypoglycemia for 82-3 days. What happened with this? Quite safe molecule. We know DPP4 inhibitors are very safe. They don't cause hypoglycemia. But taking a molecule which is going for such a prolonged half-life, for such a prolonged half-life, we do have some apprehension about maybe causing some hypoglycemia, some increased risk of hypoglycemia.
Glucose dependent है तो I don't have chances but we will have to talk. Glucose dependent in kidney failure. In kidney failure not happen.
But that's a relevant question. Ramzan में you need a shorter acting drug as a much longer acting drug.
रमजान में शॉर्टर और लॉन्गर एक्टिंग ड्रग का अपनी जगह बोला सर, जिस ड्रग से हाइपोग्लाइसीमिया ना हो हमें वो देना है. sulfonylurea has to be avoided. इंसुलिन के डोज उस हिसाब से डोज एडजस्ट करने हैं.
रमजान में तो लंबा पीरियड है, आप उसको स्किप कर लीजिए. रात में खाना बहुत बढ़िया होता है.
छोटा हाफ लाइफ ज्यादा बड़ा हाफ लाइफ कम.
We need to document, I guess. We'll have to document.
this molecule will be better off.
हाँ,
हो भी सकता है.
उल्टा बॉस यहाँ पे
रमजान में खाने का पैटर्न का पता नहीं है, कब खाएगा क्या नहीं खाएगा क्या खाएगा. हफ्ते में एक गोली दे दीजिए, ग्लूकोज मीडिएटेड ग्लूकोज कंट्रोल होगा.
That way, vildagliptin was better suited for these kind of patients. कि आपने रात में खाना खाना है, शाम से खाना है, तो हो गया कवर.
तो सर सीटाग्लिप्टिन भी बेटर है. तो
Sitagliptin
लॉन्ग
but-
एक्टिंग हाफ लाइफ है. नहीं
But ये साथ में
ज्यादा
थोड़ा सा concern
टी
है.
हाफ अगर ज्यादा है तो पीक का जो है वो रफ्तार कम हो जाएगा.
हाँ,
तो उसमें जो है जब लॉन्ग हाफ लाइफ है तो वो तो एक प्लेटो बना के चलेगा. तो उसमें पीक्स तो आने का सवाल ही नहीं हो रहा है. हाइपोग्लाइसीमिया होने की संभावना इसमें बल्कि कम रहेगी एज कम्पेयर टू दूसरे. ग्लिप्टिन में वैसे ही कम रहती है. ग्लूकोज डिपेंडेंट.
Sir, in hypothyroid patients, like, any comments on that?
I don't feel there is any study suggesting DPP4 inhibitor having any impact on hypothyroidism or on thyroid functions.
Those patients do come with comorbidities like
हाँ,
type
तो
2 diabetes with hypothyroidism.
so there is no issue with hypothyroidism as with other DPP4 inhibitors. You may use this drug safely without any issue.
I think 25 milligram use करने के लिए 50 वाली is a score.
Every
50 milligram is a score tablet.
so every tablet is scored one, but it's not means in the study that we can give half. It's that way.
नहीं तो 25 मिलीग्राम वाली आपके पास 50 और 100 वाली है, 25 वाली भी है क्या?
25 is available.
Yes, yes, available, sir.
This one.
That's great.
On the board, that's it's not mentioned on the board.
It's not mentioned because this month only 25 mg has been added, and now it is available in Lucknow also. 150 and 25. Sir.
150 and 25.
So just to give more clarity, with due permission of panelists, 3 strengths are there. 100 mg. All the trials that Dr. Chandra has mentioned conducted over 100 mg only. That's the standard dose. In CKD patients only, for the dose titration purpose, we have this 50 mg and 25 mg. And one more thing, means it was a good discussion happening, and thanks to sir giving another angle of this pill burden. So what I have read and gone through, in the coming years, it is the future. We are way ahead of time. Even his questions are way ahead of time. In hypertension, you will see once weekly therapy in the coming days. Even you have seen semaglutide that Dr. Chandra has mentioned once weekly. Vitamin someone was mentioning once weekly. So it's not about only business point of view, something for the patient's benefit also. Another thing, one discussion came, even vildagliptin, another gliptin is not US FDA approval. But it is highly successful in India because gliptin suits more to the kind of persona we have. South Asian patients, and it's not the European countries. All the trials conducted in South Asia means something very much common to our Indian this thing. And US FDA, someone has mentioned, this is what I was discussing with sir even, no CVOT means obviously US has a strong parameter and huge financial burden is there if you want to do the trials there. So Takeda, highly successful, known for this Voglivos kind of molecules that it has produced in India, has also tried there, but because of the financial constraint only, it has taken the decision back to conduct that FDA, and DCGI has even made it clear that there is no CVOT outcomes required, because vildagliptin also, if you check, there is no FDA approval, but it is highly successful. Means, I mean to say, it has all the features of gliptin, like sitagliptin as sir has mentioned, vildagliptin, additional benefit because of that fluorine atom substitution as sir has mentioned, that ensures this 7 days once weekly therapy. Otherwise, it has all the benefits of gliptin that we have, and that is highly successful, and that is even 12,000, more than 12,000 crore market in India. So that's a simple thing about this. Yeah, you please continue.
एक और चीज़ है, why aren't other gliptins में फ्लोरीन डाल के हमको क्यों नहीं once a week कर देते हैं?
मेडिसिनल केमिस्ट्री वाले को
Look, I'm not again. I think, to be very frank, this is a futuristic drug. We are in the era of once daily dosage regimen, and we are going into the era of once weekly and then once monthly and once yearly dosaging में हम लोग जा रहे हैं. Diabetes में हो रहा है, अब hyperdyslipidemias में हो रहा है. तो we are going into those drugs now, and futuristic drug है. I think इनका भी दिन आएगा.
HIV में भी हो गया वन से वन
ART ऐसे कुछ आया है once
आ
month.
गया नहीं फिर ट्रायल भी आ गए हैं फिर रिजल्ट भी आ गए हैं
अभी presently we are in the era of once daily dosage.
HIV का वैक्सीन भी एक कोई
Recently आ गया, yes. Yeah, no person.
कोई पाइपलाइन में और फिर अभी
नहीं, vaccine has been introduced. कहीं कुछ approve हो गया, FDA ने approve कर दिया.
there was one more thing DPP4 inhibition morning after dosage which was said that minimum 80% DPP4 inhibition 24 hours after the dosage should be there.
इसमें
This was
77% 7वें दिन तक.
7वें दिन की morning after that.
हाँ, 7वें दिन के मॉर्निंग में 77%.
77 तो नहीं है ना 77 नहीं 80% से कम नहीं होना चाहिए.
7वें दिन तक है बॉस.
दूसरी टैबलेट खा ली.
7वां दिन दूसरा खा लो ना.
सर ऐसा टेक्निकली देखें विल्डाग्लिप्टिन का 40% रहता है आफ्टर 24 आवर्स.
सिंगल डोजेज का.
हाँ सीटाग्लिप्टिन 80% रहता है. व्हाट सर इज मेंशनिंग 7 दिन के बाद भी this drug having that 77% DPP4 inhibition, so that ensures that throughout
मतलब सैटरडे नाइट पार्टी नहीं
सैटरडे को संडे खाएगा
इसका मतलब ये सैटरडे नाइट पार्टी नहीं करना.
अगर 24 घंटे लेट भी होगा कोई दिक्कत नहीं.
हाँ 24 घंटे एज सर हैज मेंशन्ड फिर वो साइकिल बस हमें रीगेन करना है.
साइकिल मेंटेन करना. विटामिन डी के साथ वो दे दीजिए आसानी से.
दिस इज एन इनोवेटिव आइडिया.
विटामिन डी से होती है.
विटामिन डी के साथ.
अब डॉक्टर को लिखना ही है
वन से वीक.
तो फिर संडे को रहते तो संडे को विटामिन डी का संडे को ये
वन से वीक हो जाएगा ना कॉम्बिनेशन.
जैसे एटोरोस्टैटिन के साथ आता है वैसे कर रहे हैं. दैट वे यू कैन
पॉइंट्स वेल टेकन.
पिल भी कम हो जाएंगी और एडवांस भी बढ़ जाएगी.
Manoj sir, your take on this drug? आपके final comments.
Well, Dr. Chandra has very aptly described this drug as a drug of future, and I also agree with that, that any innovation that is coming is for the benefit of the patient as such. And it is the prerogative of the physician to place that particular drug in a particular perspective. So, taking on to the question that Dr. Chandra had put, whether putting the patient on a single drug like a DPP4 inhibitor once a week and then putting him on so many other drugs together, is it going to really serve any purpose? Now what we are talking about is a situation where the patient has got a large number of pills in his prescriptions. He is already taking metformin sulfonylurea to the optimal dose. He is already on DPP4 inhibitors, he's already on SGLT2 inhibitors, maybe on a Rocklibose, still not controlled. Now the next step is you want to add another drug. Now in that particular situation, maybe you'd like to add a DPP4 inhibitor or you'd like to add a GLP-1RA, whatever your choice is. Now suppose you want to put the patient on a DPP4 inhibitor. This could either you could add a drug on a daily basis for next 7 days, or you can put a drug once a week so that you can just reduce the pill burden. We're not talking about reducing the pill burden of a patient who is initiating on anti-diabetic agent. The pill burden arises when the patient is already on a number of drugs. That is the right time when we need to compromise on the number of drugs so that we can get the best optimal results and the best compliance. So I think what you were talking of as an initiating drug, I would think of using this drug as a drug to reduce the number of pill burden so that the number of drugs that are being prescribed can be reduced. So this will probably happen much later in the course of the disease process. So I think this is another indication. In a situation patient is already on so many anti-diabetic agents, you want to add another drug. Why not give once a week rather than giving a once a day drug? So this could be a possibility. Just to add on to what Dr. Chandra was talking of, the other possibilities of using this drug as compared to using. Now, of course, if you are using a metformin and DPP4 right from the very beginning, then probably this is not the drug of choice at that particular point of time. So it has to be your perspective. The HCP has to decide where he wants to put that particular drug. Just this drug is available, so we now have to decide who is the right patient to be prescribed.
सर एक चीज़ और है, सेफ्टी से फैमिली वाले मेंबर को पता चलता है मेरे को डायबिटीज़ है, टाइप 2 डायबिटीज़ है, मैं दवाई नहीं खाऊंगा, हमको लाइफस्टाइल समझाते हैं, लाइफस्टाइल तो नहीं करो, और उसके बाद हमें बैठवाते बताते हैं, वो फिर भी नहीं लेना चाहता, तो उसको कह सकते हैं अच्छा हफ्ते में एक गोली तो खा सकते हो, तो वो पेशेंट मेरे को लगता है सेटिस्फाइड हो जाएगा हफ्ते में एक बार खाने के, और दूसरा जो सोसाइटी का स्टिग्मा है उसके ऊपर शायद वो भी कुछ छिपा ले जाएगा, कुछ स्टिग्मा भी नहीं लगेगा, और हमें थोड़ा ट्रायल करके देख लेंगे, सक्सेसफुल है तो मुझे कंटिन्यू करें इन प्लेस ऑफ मेटफॉर्मिन। मेटफॉर्मिन तो डेली खानी पड़ेगी, फिर मेटफॉर्मिन में हमें ये भी ध्यान रखना पड़ता है कि गैस्ट्रिक प्रॉब्लम्स होती है उनको, डिस्पेप्सिया की प्रॉब्लम्स होती है, प्रोटीन की प्रॉब्लम होती है, ओबीस से नहीं हो और DPP से होती भी नहीं है।
We're not taking it as a replacement for metformin at the moment, but of course, जहाँ पे आप बता रहे हैं कि metformin नहीं देना चाहते हैं, वहाँ पे I think we can always go ahead. Situation, yes, it's a situational problem, and every physician has got own what you call privilege to prescribe this medicine wherever he feels this will really benefit the patient.
So what I can get is my last comment is that every drug has got its own unique property, and we have to individualize the treatment as per the requirement. So yes, this drug has got its own place, and we have to individualize the place, and wherever we feel appropriate, we may use it. Thank you very much.
Thank you everybody, thank you respected dignitaries on the dais for such a lovely interactive session. Now I think I'll invite Dr. Chandra on the stage. Dr. Manoj sir, please facilitate Dr. Chandra, the speaker.
Something unique in front of us. Both these personalities on the stage have completed the MSc. MSc is a very tough examination, very tough, very prolonged duration drilling, and Dr. Manoj Srivastav and TP Chandra both have completed this course of MSc in diabetes.
Chandra sir, please come on the stage. Dr. Manoj sir will facilitate. Thank you, sir. Sanjay sir.
आपने बड़ा वाला सवाल पूछा था, आपको बड़ा वाला
यही क्या किया आपने का सवाल पूछा उतना ही लंबा पेड़ दे दिया
समझेगा बहुत छोटा सवाल
ये मन से दिख पा रही है
Lastly, Dr. Joshi sir.
जोशी राव भाई
घरों वाला दे
सर सारे फैकल्टी एक साथ सर ग्रुप फोटो सर प्लीज
Sir, take it. Sir, may I invite Dr. Jeevan Prakash sir to facilitate Dr. Manoj sir. He is the president of UPDA right now. Dr. Manoj sir has taken the UPDA body to different levels. We have been very active in starting the project. Thank you.
So just request.